Good afternoon, and welcome to the presentation entitled Friend or Foe, the Implications of the Final IRS Regulations on Your Hospital's Community Health Needs Assessment. And I'm Debbie Thompson, President of Strategy Solutions, and I apologize for my raspy voice. I'm recovering from bronchitis, but thought that when I rescheduled this presentation once, by the time it came around again, that I would have my voice back. And it's not completely back, but I didn't want to reschedule again. I also want to say that if any of you have questions during the course of the presentation, please feel free to send them to me via the chat feature, because I'm going to mute everyone's line as I get started here so that we don't have any paper rustling or other background noises like people's barking dogs or colleagues walking into the room or phones
The conference has been muted.
ringing that would distract somebody who's listening to the recorded version of this. Our presentation today is going to cover a couple of things. We're going to talk about the final Community Health Needs Assessment guidelines, and that really include adopting most of what the preliminary guidelines were. But there's a couple of new things that were in the final published guidelines, along with a couple of things that I would consider to be omissions that I personally was expecting to be in the final guidelines that weren't addressed at all. So I'm going to give a few editorials about that, and also give some strategies about how to prepare for your next community health needs assessment process by evaluating your past implementation strategies. One of the things that I've been finding is I've been working with hospitals in various parts of the country for the past few years, that this whole idea of evaluation is something that many organizations are struggling with. Many organizations are struggling with even how to measure the outcomes of their needs assessment implementation strategies beyond counting the number of people who participate, which is actually an output. And I've put in a few slides to talk about that process and to really look at your current infrastructure and your readiness to institutionalize this process now that it is required and it's ongoing. So these are our objectives for the day. We're going to talk about them as we go forward. For those of you who are not familiar with Strategy Solutions, our company exists to create healthy communities. We really work with different sectors in communities. We work with private sector companies, community and government organizations. We also work with those in the social services sector, including healthcare. So we have a lot of cross-sector experience that we bring to the concept of community health needs assessments, even though we've been doing them now for about 25 years. I was doing community health needs assessments long before many people knew what they were. We also believe in creating healthier organizations, and those organizations that are healthy have strong operations, strong finance and access to capital, and strong support services. We also do a lot of work with collaboratives in communities and have done those, for years and years, and bring that to our thinking behind community health needs assessments. I'd like to start off by talking about the guidelines. The letter of the law, of course, is they have to be done every 3 years. They need to look at chronic disease conditions and community health needs, look at assets and strengths, and make sure that you incorporate underrepresented and disadvantaged populations. But I always like to remind people, especially those whose hospitals and health systems look at this whole effort clearly as a mandate. It's a compliance thing. The spirit of the law is really to move us toward population-based health planning and to look at how do we create that delivery system of the future and manage the health of a population, not just take care of people after they're sick. And if you embrace the ideas behind the spirit of the law, you can actually use this community health needs assessment process as a vehicle to help move you in that direction. What is, yes, a required mandate can help you move your hospital and health system toward creating a healthier community in a way that can be really useful and achieve a return on investment for your hospital or health system. So we come at this from the spirit of the law perspective, even though we can certainly look at all of the compliance regulations and do help our clients really look at those things. Here's some of the key elements of the final regulations. And I'm going to go into each one of these in detail, so I'm not going to read them now. The first one is collaboration. The second is input from persons served. You got to identify the resources and facilities to address significant needs in the community. The implementation strategy must describe how the hospital plans to address each need or why it doesn't. The extra time is available for implementation strategy development and posting. This is one of the new changes that came out in the final regs that wasn't in the previous draft regulations. They really did differentiate between a needs assessment document and an implementation strategy. The report itself must include an evaluation of the impact, except it gave no guidelines for what they expect from an evaluation. So I'm going to speak to that. And there are some exceptions in it for new, acquired, and terminated facilities. The final regulations also have a lot of information about financial assistance policies and the other parts of the IRS regulations that don't deal with the community health needs assessment. The community health needs assessment doesn't need to be connected to the financial assistance policy either. So this webinar is really directed only at the regulations as they relate to the community health needs assessment itself. So I'm not going to speak to any of the other components of the final regulations, even though if you're an accounting type or work in the finance department, some of those other components might be very important. But I'm really talking about each of the elements as they relate to the community health needs assessment. First of all, collaboration. It's encouraged, not mandated. And some people actually made the case to mandate collaboration within communities. Some states are encouraging different organizations in the community to work together, such as the state of New York really mandates their hospitals and their public health agencies to work together. The IRS doesn't really do that. But collaboration is encouraged, and there's really a lot of flexibility here in the regulations about how the joint data collection can be done and be reported. And even though there's a number of bullets here on a couple of different slides, I actually have 3 slides about collaboration. The bottom line is that if you collaborate with other organizations, what each hospital's specific role is must be articulated. And you've got to do a good documentation of the methodology. So here's the requirements. Joint data collection with any number or combination of different types of facilities is all great. Each hospital must create a separate report unless the group adopts a joint report and a joint implementation strategy. So you can have a joint report and a joint implementation strategy. You can have separate ones and separate reports and implementation strategies, but share different specific information and report language. So any combination is possible of the various facilities being involved. You can share information across multiple ones. It really depends on what's going to be in the best interest of your organization. You can also conduct a collaborative community health needs assessment, then add in specific information that relates to a specific population or need that relates to one hospital only. Say, for example, 3 hospitals that are unrelated happen to be located in a county together. One is a specialty hospital or a children's hospital. That one facility can add in extra data into its report, even though all the rest of the report is joint information collected with other facilities. So you can do that. But again, the reports of collaborating facilities should differ to reflect any material differences in the communities served by those hospital facilities. And communities can be defined however the facts and circumstances explain, and I'll talk about that in a few minutes. There's some very specific requirements around how you define communities. And the methodology of the final reports must specifically state the names of the providers and articulate the appropriate nuances of data collection, analysis, and any differences in roles in the implementation strategies. And I'll talk about that as well when I get to speaking about the actual implementation strategies. But, again, the bottom line is, as long as you explain what you're doing in a very detailed way, and you have a summary or a tool so that the reader can easily find each hospital's portion of a joint implementation strategy. Okay, so you have to be able to search. And if your hospital's working on this, this, and this, you actually either have to, have a search feature that can find these pieces, or have it like an appendix. Like if say you have a joint implementation strategy, and hospital X has roles in, say, 2 of the 3 goals, you probably ought to put an appendix on your report that shows just the things that hospital X is working on, and a footnote back to the table of contents to be able to find that. I think that's the spirit of what they're suggesting there. And the other thing they do note is that each collaborating hospital's completion date is the date they publish their report on their website or on the website they're posting it on. And it doesn't have to be the same day for all collaborating entities, but they all have to be posted before the deadline date, whatever that deadline date is for your organization based on its fiscal year and cycle and whenever it's due. The regs say you have to have broad community input. And again, they add a little bit of specificity from what was in the previous draft guidelines. You've got to summarize the input by such person, as well as how and over what time period the input was provided. So the methodology needs to be very specific in terms of input coming from a particular place. You must outline the methodology, whether they were meetings, focus groups, interviews, surveys, or written input. I did a whole section of earlier webinars about the fact that hospitals need to have mechanisms to get and gather written input on their survey, on their community health needs assessments. And they probably ought to set up policies in their organization to centralize any letters that might be received or any written input that might be offered by someone. That, if a letter goes to the president's office, for example, about the community health needs assessment or one of the implementation strategies, that the information from that letter ought to be combined with anything that might have been received by the person who is the coordinator of the community health needs assessment. I also recommended to our client hospitals that they put a mechanism right on the web page where the community health needs assessment is housed to click here if you want to provide some comments on the community health needs assessment or the implementation strategy or want to provide input, even though the last I heard from any of our client hospitals, that's not a feature that's well used. But as part of the needs assessment, the IRS regulations recognize that written input can be a way of providing input into the community health needs assessments. And, those of you who are conducting them could be advertising. Hey, if you have comments about what community needs are, go to our webpage where the needs assessment is and fill out the comment card there. So those are ways for you to gather input from various people, and you can use the mechanism if you have it on your website as a way of gathering more information from the public that you might not otherwise get. You also have to look at and describe those methods that provide information from medically underserved, low-income, or minority populations being represented, whether it's the consumers themselves or agencies or individuals that represent them. And organizations that provide input should be specifically noted, but individual persons do not need to be named, even though you are certainly free to list the names of individuals who participated in the process if you note all the names of those, say, that participated in stakeholder interviews. The community served. This is pretty consistent with the draft guidelines. The community served may take into account all the relevant facts and circumstances, including the area served by the hospital and the target populations. So a lot of discussion and input, if you look at the letters and read the editorials about the input that was given into this process to the IRS, a lot of people were defining the service area for the community health needs assessment similar to how hospitals define their service area based on a percentage, usually 70% or something in that ballpark, of the where the patient, where the geography, where 70% or 80% or whatever number, 75, whatever number people want to use, percent of the patients come from. Now, saying that, you can define your population by geography or by special population. Like, for example, a women's hospital can define their population based on women. A children's hospital can define their population based on children, or can define a population by specific disease conditions. We worked with a specialty hospital doing community health needs assessment that defined their population as anyone in the United States that had a particular condition, because they were one of the leading specialty hospitals in the country for that particular condition. You may not, however, define the community to exclude medically underserved, low-income, or minority populations who live in the geographic areas that the hospital might designate as its target geography, okay? Unless the populations are not part of the patient population. So, for example, if you have a women's hospital, you can certainly exclude the men who are low income or minority within the geography of that hospital, but you can't exclude low income women. So they just, try to make sure that you're not excluding some population. You also must solicit and take into account input from all of the following sources. And this is a little bit more specific than the draft guidelines were. At least one public health department or equivalent with knowledge, information, or expertise relevant to the health needs of the community. Now, if you're using public health data, that can be considered the input. So if you're using, the public data from the Pennsylvania Department of Health, for example, that can be public input. It makes it certainly stronger if you have someone on your steering committee that represents the health department, or a stakeholder interview with a health department representative. That strengthens those things. But any of the above, again, according to my interpretation of the guidelines, as long as some representation is there, that would suffice. You also want to have members of different medically underserved, low-income, and minority populations, or individuals or organizations representing the interest of those. So if you can't convene a focus group, for example, with people from a minority population, or like for another example is we've worked in communities where there's significant prison populations, and those populations have special needs. It may be difficult to convene a focus group of inmates, although if you're working with say a pre-release organization as part of your steering committee, you might get access to a group of inmates for discussion as a focus group. But you could interview someone that represents the interest of those folks, that someone who works with that population and knows what the needs are. Again, that would suffice. But you really need to look at what are those special populations in your service area that might have a particular need, and get their input. You know, we've also worked in different places in Pennsylvania, for example, that have Amish populations. It's sometimes difficult to talk to Amish people directly, but there are people who work with them on a daily basis that can provide input into the process. Other input. I spoke to this already. Written comments received on the most recently conducted needs assessment and the implementation strategy. So any information that you have collected or was sent in needs to be included in your new report. You can also get input from any or all of these above, including consumers, consumer advocates, nonprofit organizations, academic experts, school districts. You do not, according to the guidelines, have to get input from all of these people. But you can certainly get input from any of them, depending on what you feel the needs are in your community. And the guidelines kind of encourage you to be as broad as possible and look at input from other sources outside of just your hospital group or your steering committee to be able to give you a well-represented cross-section of the different community needs. There are some exceptions. If a hospital is acquired by another hospital, the requirements must be met, and it's not just the CHNA requirements. It's all the requirements from the regulations associated with this publication must be met by the last day of the organization's second taxable year beginning after the date which the hospital facility was acquired. So in other words, if your hospital is bought out or acquired by another one, you kind of get a get out of jail free card for a couple of years, and then the acquiring parent organization has to make sure that your organization's requirements are met within the next couple of years. So if you're a terminating hospital, you don't have to meet the regulations for that taxable year if you cease operation under one name before the end of the taxable year. So if you transfer ownership anywhere in midstream, you don't have to file, or you don't have to meet the stipulations of the regulations for that year. But you then become under the acquired facility regulations. And the same thing follows true for new organizations. If there's a new hospital coming online, the requirements must be met by the last day of the second taxable year beginning after, whichever is later, the effective date of the determination letter if they're a new 501c3 charitable hospital, or that the facility was licensed, registered, and recognized as a hospital. Like, for example, we know an organization that opened a new hospital. They opened it in May. The fiscal year ends in June. And they didn't get a new IRS determination letter because it's part of an organization that already exists. So they have to meet their requirements by the last day of the 2 years after that beginning date. So if you're not, none of this applies to you if you're not acquiring, merging, or building a new hospital. Now, the required documentation includes the same things that were in the draft guidelines. Definition of the community served, processes and methods, even though now we have more specificity in terms of the methodology that needs to be documented, input from the person served, the prioritized description of the significant health needs, along with the description of the process and the criteria used to identify the needs. This is an area where there's a little bit more specificity in the final guidelines related to what they're looking for. They really want that method of choosing well documented in the final report. They also want resources potentially available to address significant health needs, which is a list of community agencies and assets, including the hospitals. And that's an interesting addition, I think, to the final regulations. They do say including the hospital's resources. So I've and we did a lot of community health needs assessments the last time around, and a lot of organizations, as they looked at community assets, gathered and listed assets outside of their own hospitals, organizations, programs, and facilities. The final guidelines say including the hospitals. So that resource inventory needs, and they also say it needs to relate to the significant health needs, not just kind of a laundry list of other assets that happen to exist in the community. They really are specific about those resources potentially available to address significant health needs. And they don't say this, but you can imply from that they're looking for those involved in the process to be able to have and get information to make referrals to people who are, facing barriers, and those that are underserved, and the needs themselves can also include the social determinants of health related to healthcare, not just healthcare needs. So the things like nutrition and access to food and transportation and those things that become barriers to people receiving the care that they need or achieving the health care that they need they can all be part of those prioritized lists. And the link between the financial assistance policy and the needs assessment is not required. So you don't have to put that in there. Now they also provide some specificity about making the CHNA widely available. And this is very consistent with the previous versions of the guidelines. It has to be on a website. But they added this, at least until the date that 2 subsequent needs assessment reports are available on a website. So in other words, they want a rolling 3 years out there all the time. So if you put up your next needs assessment, you got to leave the old one up there until you have 3 up there. When you add the 4th, you can drop off the 1st. They also want you to make a paper copy available for public inspection upon request and without charge at the hospital. Again, they want 3 available on a rolling basis. And they put some commentary in the regulations about publishing a draft report. Apparently they got a number of letters about people encouraging them to require drafts to be published and then to allow commentary on the drafts from the public. But they chose not to embrace that as that whole concept as part of the final guidelines and said if you decided to put a draft out there, the draft report doesn't impact the final publish dates. In other words, if you say your final publish date needs to be June 30th of 2016 and you put a draft out there in May, it doesn't count if you don't get the final report out there by June 30th. You got to get the final report out there. But you have some time to get the implementation strategy out there afterwards, okay? That extra time for the implementation strategy development and posting is built into this process. You basically have 5 months after the end of the fiscal year that is the due date. And if you get let's say your due date to have the final posting is June 30th, 2016, you have 5 months after that to get the implementation strategy up. And if you get your community health needs assessment done early, say you get it done by May of 2016, you still have those 5 months after the end of June to get the implementation strategy up there. The clock doesn't start when you post or complete your community health needs assessment. The clock starts at the fiscal year end date. So that's interesting. So again, it gives you more time. It also must describe how the hospital plans to address each need or explain why the hospital does not intend to address the need. And that's on a need-by-need basis. The other thing I want to note here is that they do want you, as part of your 990 every year, to submit your progress. And there's, in the language of the guidelines, they talk about the progress on your implementation strategy. There's some language in there that led me to believe that you should, every time you do a progress report, mention all of the significant health needs and note the ones that you chose not to implement as well, kind of on an ongoing basis. But that, other people that read it may have different interpretations. But, my advice is to keep that idea out there. We're addressing these 5 needs, and there's these other 5 needs that we're not addressing because. And put that as kind of a footnote on all of your reporting as you go through it with your implementation strategy. This is new. This must identify the resources that the hospital facility plans to commit to address the health need, along with any planned collaboration, as well as the impact of the actions. So the strategic investment budget or the community benefit budget related to the implementation strategies must be identified. And I know a lot of organizations that had trouble putting dollars to stuff, especially new stuff that they were doing. They could go back retrospectively and look at things that were reported as community benefit in previous years and say, yeah, our 990 last year said that we did, we put $5,000 into this community screening program. We could budget $5,000 to continue it. But new initiatives, let's say for an employee wellness initiative, some hospitals are struggling with identifying, well, what are the resources that we're going to commit to doing this in the beginning, but yet they want you to do that, as well as the anticipated impact of these actions. Although I find it fascinating that the final guidelines did not give a lot of information about how do you evaluate. You should have some type of evaluation plan, even though, again, the regulations don't say anything specific about it. But what it does say is the anticipated impact of the implementation strategy must be included in the implementation strategy. And in addition to attaching the strategy to the Form 990, annual updates must be included on the Form 990 to describe the actions taken during the tax year, or if no action was taken, the reason why no action occurred. So that, that's part of the language that causes me to say you ought to mention that every time. And you also have to, at the end of the 3-year period, do an evaluation of the impact of any actions that were taken since the hospital facility conducted its immediately preceding CHNA. Again, they give no specificity to, well, what's an evaluation? And, so what we're recommending people to think about is to ask themselves the question, how prepared are you really to evaluate impact? And there are some things that you need to think about. One is, do you want to go down the path of really looking at the Institute for Health Improvement's triple aim that includes health status indicators, experience of care indicators, and cost? Because sometimes cost savings over time are the biggest impact. Here's some terms. Evaluation here is used in a couple of different ways. And I have a whole training program just on evaluation that I've done for a number of folks that I'd be happy to do for your organization if you feel you need it, to think about how do I set up and really implement an evaluation process, because sometimes it means gathering data in somewhat of a different way. And I'm going to use the word program to be any object or efforts that's being evaluated. And any one of your implementation strategies, even if they are a health fair or they're a lunch and learn program or they're a diabetes education program, all of those, I'm using the word program to describe the whole universe of those kinds of strategies, because you want to evaluate all of your strategies, not just those things that would be considered a formal program, like the Dean Ornish cardiac program, if your hospital is implementing something like that. Here's a list of types of programs. It could be a direct service intervention. It could be a community mobilization effort. It could be a research initiative. It could be a surveillance system. It could be advocacy work. It could be a social marketing campaign, say to get people to encourage breastfeeding, or to, sign up for the patient portal, for example, to take more empowerment of your personal health care. An infrastructure building project. I've been involved in infrastructure building projects where communities made investments into the infrastructure of the health department in order to be better equipped to track and manage public health data. It could be a training program. It could be some type of administrative system. There are different kinds of measures, and this is confusing to a lot of people when it comes to evaluating what they're doing. We count people. That's how a lot of us track our community benefits, the number of people that show up at a program. But the number of people who show up is an output measure. It's not an outcome measure. Yes, we can look at process and output measures. Are we reaching the people we should reach? Did we do what we said we were going to do? For many people, their year one implementation strategies, including looking at the feasibility of doing something. Like, for example, one of our clients looked at the feasibility of a mobile van. They did that. That was a process outcome. You either did it or didn't do it. And now that's not going to, they deemed it not feasible, so they're not going to continue to look at it for a while, even though they may revisit it. Outcomes are things like the knowledge, attitudes, behaviors, or other things that change because of your program or effort. And the impact is the long-term changes that are the result of the changes in the outcome variables. The next couple slides here show some examples of that. For those of you who are not familiar with these concepts, you've got to build a logic model. And I know some of you who are on this presentation have actually seen the evaluation presentation that I've done, so I'm not going to belabor these slides. But I offer them for folks who haven't really thought about this before, that looked at, our process, did we reach our target market? Did we do what we said we were going to do? Does our program have strengths and weaknesses? Our outcomes are things like knowledge, attitudes, behavior. Our impacts could be decrease in hospitalization, decrease in cost associated with care. Here's actually an example of a logic model for a intervention program. For a health screening, looking at doing screening and lab tests as part of a health fair. The outputs would be who we reached, the number of program participants, including any special population. Say we did a particular outreach for the Hispanic population in a community. Did we actually get them to come? A short-term outcome would be the number and percentage of people who come back for the test results. We worked with one organization that would do kind of a two-part health fair where people would come in for testing on Tuesday and then come back to see the results on Friday of the same week and then refer them to do something with it. That would be the fact that people came back is a short-term outcome. The number and percentage of people who schedule and attend follow-up with their doctor or actually get a diagnosis based on their results, or that care management is implemented. And say, for example, we're looking at A1C levels, the fact that they decreased, you can look at increased quality of life or cost associated with decreased ER visits if people are being appropriately managed through physician practices. But the thing to remember is that objectives should be SMART. They should be specific, measurable, achievable, results-oriented, and time-bound. We're going to improve our follow-up by 10% over by June of 2015. So you want it to be specific and measurable. I offer this as an example, and I'll have Kathy send all the participants this template. We created a health fair evaluation template for some of our clients that allows you to look at, especially if you're doing, because we know many people who do the same kind of health fair every year. And because they're people in their communities, folks come back year after year. So this gives you a mechanism to see it. Did people come back? Did you follow up and do something as a result of last year's learning? If the answer to that is yes and they did something, you can actually count those as outcomes from your previous effort. And, was the information that was presented on diabetes care management, was that very useful, somewhat useful, or not useful? So that percentage of people who consider the information very useful can be considered an outcome for a particular education program. You can also look at how likely would people be to do something as a result of what they learned. How likely would they be to recommend our events to a friend? Contact us if you need assistance. Follow the advice presented today. Follow up with your doctor for more information. Again, intent to change behavior can be considered a short-term outcome. But then you need somebody to tabulate the survey results. You end up with a tracking mechanism issue. Here's some examples of data that can be used to evaluate the impact of a financial assistance effort or program. Many people are doing financial assistance programs, and the outcomes aren't simply the number of people who are contacted. Here's a whole laundry list of things that can be used for evaluating the impact. Some are more short, medium, and long term, and I didn't differentiate them in this particular slide, even though I did do them in this example. The data can be used to evaluate the impact of a breast screening program. The outputs are the number of women attending a screening event. The outcomes are the number of attendees who are actually screened, the number of women given vouchers for a free mammogram, those who schedule it, those who actually come and get them. The impacts become the number of percentage of breast cancer that are actually detected, because now you can quantify the difference in the care cost between somebody who is diagnosed at stage 0 or 1 versus somebody that's diagnosed at stage 4. You can start to quantify the impact of that based on your hospital's experience. I also have created an assessment, kind of an assessment tool to get people thinking about how do they want to institutionalize their organization's community health needs assessment process. There are a number of questions that you can look at, because some people take a very traditional approach to a community health needs assessment. It's hospital focused and it's very much related to community benefit only, versus those people who look at it broadly and look at better care, better health, lower cost, and look at the entire triple aim. Some people are looking at their community health needs assessments for compliance purposes only. They want to do the bare minimum. They want to be able to just say, I'm going to get it done and move on to the next thing, versus those organizations that look at their community health needs assessment as a catalyst for change, not only in their organization but in the community. And the infrastructure you want to build on an ongoing basis is going to be different if you look at yourself as wanting to be a catalyst for change versus merely be compliance focused. Are you looking at your approach simply from a healthcare approach or a broader community approach? We have one client that the last time their community health needs assessment was done, it was very much hospital-centric. It collected all of the data. It invited people to be part of the steering committee, but the implementation strategies were very hospital-focused. The report was written from a hospital-focused perspective, and even though they were partnering with their community on a number of initiatives, the community partners said, hey, why is this needs assessment process so hospital-focused? It should be a collaborative approach. And some people started from a broader community collaborative approach from the beginning. And again, depending on how the organization wants to approach it, it's entirely up to the individual hospital. But depending on where you are on the continuum, you may build your infrastructure differently. Do you want to build your internal capacity to manage this on the inside? Many organizations, especially those that are larger, want to build their internal capacity to do this on an ongoing basis because it's more cost effective for them. Or are you in a situation where your hospital is like, well, I'm never going to have the technical expertise to do this. I want to outsource it or outsource parts of it and insource other parts of it over time. We've been working with a number of organizations to insource different component parts of it and learn how to do these pieces of the needs assessment so that they don't have to rely on external consultants. Is your stakeholder engagement process a point in time, once every 3 years, or as part of the needs assessment process, or is it continuous? Is it something that we want to do once a year? We have clients that were bringing their steering committees together at the end of each fiscal year to evaluate what they were doing and give input on, do we continue to do these things or do we do something else? That's entirely up to you. There's no formal guidelines there's no prescriptive guidelines about how you do some of these things. And we see different people taking different approaches. You just want to decide what's going to be best for you because one size doesn't fit all. You also want to look at what kind of program approach do you want. Are you taking an informal approach or are you taking an evidence-based approach? Now, there was less language in the final regulations than there was in previous iterations, and especially some of the conversations around the guidelines, that the intent over time is for organizations to implement evidence-based practices as part of their program design. But there's nothing in the final regulations that say that that's prescribed. What kind of planning do you want to do? Do you want to do separate, and I'm talking about planning for the needs assessment and the implementation strategies themselves. Some organizations take a very separate approach. Our community benefits stuff is over here. Our community health needs assessment stuff is over there with the community benefits stuff. Whereas some hospitals integrate their strategic planning and their community benefit and their implementation strategies at the highest level so that their strategic plans for the entire health system are driven by community needs and respond to community needs. And they also tend to be the ones that are looking more toward the triple aim as well because they're lowering costs associated with some of these intervention strategies. It's also important to note, and I tell people this all the time, there is nothing in the IRS guidelines that say your implementation strategies must be equated to your community benefit. So in other words, you can have what I'll call mercenary or profit-making implementation strategies. That's okay. You can do outreach to women who have commercial health insurance to get their mammograms. Yes, you can. That's perfectly acceptable. You can promote your digital mammography services. And yes, while you're at it, you can give the vouchers for free mammograms to women who can't afford it or who don't have commercial insurance. Those are all possible. And some people get confused by that. But again, your approach to the community health needs assessment can be separate or it can be integrated. Your outcomes, you can continue to look at only outputs. But the regulations do say they want you to evaluate impact, even though they're not specific in how they expect you to do it. And you can do a formal evaluation process. You can do a very informal evaluation process. I don't recommend that at this point that you do none because it very clearly says in the regulations that you need to evaluate, you need to speak to in your written report some evaluation of your previous activities. So that is something that you must do. As part of your packet, I am going to send you, I'm going to share my Word application with you right now and show you this assessment tool I put together. I actually put this together last year as part of a presentation I did for the Association for Community Health Improvement. But what it does, and we'll send this to you, what it does is it gives you a tool to have a conversation with folks in your organization about what kind of approach do we want to take. Now, there's a little bit of bias built into this, because on the left side of this, and the scores of 5, really look at how innovative are you in moving your community health needs assessment to an integrated process and toward the triple aim. Again, that's the spirit of the IRS regulations. That's our bias. We tend to encourage people to be thinking in that direction. But we recognize that a lot of folks aren't there yet and need some help and support to get there. In some cases, the folks that are the coordinators for the community health needs assessment or the community benefit worker, we need to move in that direction, but the folks in the C-suite aren't quite there yet, and the board doesn't really know anything about this or think about it in any strategic way yet. This document gives you a tool to say, where are we in our overall approach to innovation? Are we an innovator? Are we more of a follower in terms of we want to make sure that other people do things we'll do it after it's proven by somebody else. We'll let the risk takers go out there and do it first. But beyond that, the rest of these questions, do you want to move to population-based health planning? Are you interested in moving toward the triple aim? Where are you on the community collaboration continuum? This tool gives you some operational definitions to look at, where do we want to be? Are we happy that our China is managed by the hospital or, another single entity's leadership? Or do we really want it to be a broad community collaborative? It's okay to be on one side or another. There is really no requirements that you be in a certain place. Some people are wanting to move toward the descriptions on the left, but that's entirely up to your organization. And some people are just having trouble facilitating the conversation and recognizing that you can be far on the left on some aspects of these and far on the right on other aspects, and that's okay too. Be comfortable in your own skin as a healthcare institution and do what works best for you, and figure out how to build the institutional capacity to continue to manage this in a way that works for your organization. And that there's some succession planning for when people leave. Because we've worked with a number of organizations that we've kind of helped train the new person that's come in after the person who coordinated the needs assessment left. And they're like, oh my goodness, we don't know what to do next because we've never done this before, and nobody else here in the hospital can answer questions for me. So you do want to decide how you want to institutionalize your process and determine on which elements you want to be perhaps more progressive. That's my value judgment. Where you want to be on the continuum for each one. And it's entirely up to your organization. But you have to ask yourselves the question, have we institutionalized the process? Do we want to make it the needs assessment the driver and evaluator of our strategic and operational improvement efforts? That's entirely up to you. But you want to be looking at how do we institutionalize it? Do we need paid staff to do certain things? Do we want to train our current staff to do certain aspects of it? What are the roles? What's the division of labor? We've worked with community groups where there's a division of labor. The hospital folks do certain things. Community agencies do other things, and they bring things together. And how do they want to repeat it? How do you want to repeat it in your community with your hospital? You want to institutionalize it. You don't want to start from scratch every 3 years and say, okay, now what did I do the last time? How do I want to do this again? Depending on your answers to those questions that I have in that assessment tool, you'll want to make some strategic decisions about, okay, how do we go from here and where do we go next? And I put this is a slide. If you want to integrate your community health needs assessment and planning processes, instead of looking at, most hospitals look at, their operational needs. What's going on in the organization? What do we need? They identify priority needs and issues to build their service lines, to promote their hospital or health system. You could also marry with that the priority needs and issues from the community health needs assessment. More often than not, they're going to be congruent with each other. There's a reason why our heart programs are so big in many of the hospitals, because heart disease is rampant in our communities. Same thing with cancer and diabetes. We can set goals and objectives that address both. Both our hospital or health systems need to advance, as well as our community strategic priorities, and then we can marry both our clinical and operational strategies with our community health implementation strategies, and then have defined action plans that include internal action plans and our collaborative action plans, and an evaluation process to say, how are we doing on all of these efforts? How are we advancing our hospital efforts? What are we doing? And does it all make sense to us? So where do we go from here? You want to, first of all, think about and ensure that each of your implementation strategies and programs that you identified in your community health needs assessment are currently being implemented. We've met some hospitals that they've created grandiose implementation strategies and aren't doing half of them or aren't doing some of them. You want to be able to do that, or reporting why you're not. It's okay that you didn't get to this thing because you decided to do 5 and you can only have the resources to do 4. It's okay to say that as long as you document that in your report. Establish outcome and impact measures and work with your IT folks to track and report them. We're doing a variety of activities with different organizations to help them figure out how to create reporting of their outcomes and impacts. Develop some type of progress report format, and don't wait for your next community health needs assessment. But you may be on the precipice of that new one, so you want to start looking at that as well, and then facilitate a discussion of what's working and not working, and document those conclusions and next steps, because you need that for your report the next time around. And call us for assistance if you're stuck. We're always happy, free of charge, to answer any immediate questions or easy questions that, how should we look at this? We have folks call us all the time of that. But we do have different mechanisms that we can contract with your organization if you do need help. We'll actually do, what I call Gapfilling Staff. We've actually been acting as a technical professional staff to support research, planning, outcomes, measurements, or be the project manager of an important initiative. We do the traditional strategic facilitator and advisor. We'll facilitate a community health needs assessment process. We'll do workshops for your board as part of a retreat process to help educate them about how they need to think about this strategically. We'll provide technical assistance to support a key initiative or one implementation strategy that's having difficulty. We've worked with some hospitals on just how do I measure the outcomes of this one teen program, because I don't know how to wrap my head around it. How do I marry the community health needs assessment to the cancer coalition, the Commission on Cancer new regulations, because that's something that's required. And we'll also do capacity building and training, develop new processes. We'll train and coach newer designated staff members to learn new skills. We'll provide educational programs and resources to fill organization capacity. And with that, are there any questions? Be helpful.
The conference has been unmuted.
Anyone have any questions?
Debbie, this is Kathleen McDonald. I'm with Dignity Health in Southern California. And thank you so much for the webinar. I have a question regarding the CHNAs that are on our website.
Uh-huh.
So currently, we've obviously been doing them for over 20 years. Is it your recommendation that we go back and put the we obviously have our current one done. Should we go back and put the other 2 prior to that on the website now?
Well, it certainly wouldn't hurt for you to do that, but it doesn't really specify anything in the regulations that you have to go back and put previous ones.
Okay.
What it states is you have to leave the current one up there when you add the new one.
Got it. So going forward, obviously, then.
Correct.
Okay.
And you can't take this one off until you have at least 3 out there.
Okay,
That's what they
Thank
want.
you.
They want the rolling 3.
Right. Okay, thank you.
Hey, Debbie, this is Ron. How are you?
Good.
Good. Very nice presentation as always. We're in the process of completing our 990 Schedule H, and the questions have changed a little bit. Some of them are very similar in terms of, what's included in the assessment that we had done. It seems like they're asking you to fill out separate forms for each hospital on this particular one, even though you referenced that, you could do sort of collaborative reports and that kind of thing. Is
right.
Any thoughts on that? I guess.
Well, what I would suggest is I would use the same language for all three hospitals.
Okay.
Because I know you have three hospitals. But you're doing the same thing, and it's all integrated, which is allowed under the regulations. You've got joint hospital implementation strategies, joint hospital reporting moving forward. I would do one report and submit it for all three.
Okay.
Because, that is the requirement moving forward. It may not be exactly what's there today, but the new regulations are on your side.
Okay, I understand. One other question, too. Obviously, we're completing these 990s. Are you seeing in the field audits or IRS coming out to actually visit facilities and check and see if what they submitted is accurate and appropriate?
That's a good question. Considering that they put nothing in the regulations that gives any operational definitions about evaluation whatsoever, I feel like they would do that first before they come out and do any auditing. Okay? Are audits down the road going to happen? I think maybe someday. But, if somebody shows up at one of your hospitals tomorrow, I guess that could happen too. But, I feel like they got other fish to fry. They're busy doing other things. I think the chances of them coming to, audit your individual hospital now, in light of everything, I think is remote. I think over time they're going to get more sophisticated. And on other webinars that I've done, I've actually forecasted that these community health needs assessments are going to go the way of HCAHPS and quality. I remember the day when we didn't do patient satisfaction. Now we got HCAHPS and 30% of our reimbursement is tied to them. Okay? I remember the days before quality. And now everybody's tracking the same quality indicators. So I think what's going to happen is over time, I think they're going to be looking at the health systems that do a better job with population health planning. They're going to look at a core set of indicators like Healthy Communities Institute, for example, is already gathering and tracking. Those kinds of data tools. We've done the needs assessments in various parts of the country, and there's a lot of commonalities, whether you're in California or you're in Georgia or you're in Pennsylvania or New York. Mm-hmm. We don't have a very healthy society. So I think we're going to be seeing, I think we'll see some definition of expectations evolve first before we see the actual auditing.
And
but
Debbie,
I think it's going to come.
All right, one last question. In addition to completing the Schedule H, they also ask you to submit some supplemental information about implementation plan updates and those kind of things. Do you have a sense for how much detail they're looking for, or should we possibly include a copy of the annual assessment that we had done that you were a part of, or is that too much information?
No, I'll tell you what, it certainly wouldn't hurt. I would encourage you, what I've done is encourage folks that if you've done an evaluation like I know you did, I would put a copy of the evaluation report, and I would put I would have one attachment to the 990 be the evaluation report, and I would either have an appendix to that report be the updated plan for the next year, or put a separate attachment with the updated plan. And an explanation in that updated plan why you dropped anything, any objectives. Like say you did a feasibility study on one objective and you found it wasn't feasible. So we're not going to address that this year. Explain that. And I would also encourage explaining I'd go back to the original assessment and any significant needs that you found in that assessment and note it in your implementation plan why you're not addressing them. Okay. And I put it as an attachment. It's certainly not going to hurt. You have the document anyway. It's just, I think it shows that you're being proactive.
All right. Thanks very much.
Debbie, what about, it's Nancy from Excella, what if, like we have a couple projects that we're waiting on evaluation from our primary care group, and they've had leadership turnover and things, and they have not made a decision yet on whether or not they want to do 2 of these projects. Just put that down that they're...
Yep.
Okay.
Absolutely. I mean,
okay.
The guidelines were very clear and simple about if you really can't do something because you're resource constrained, just tell us that. Okay. That's a legitimate reason not to do it. And even if you say you're going to do it and then find you can't because you're resource constrained, I think the same logic applies. Just explain that this happened. You can't do it for this reason. And I think that's fine. I think the bigger issue is that they want to know that you're on top of it, you're paying attention to it, and that these things are important to you, and that you're following up to find, to say, this worked, this didn't work, this is what we're doing. I think that process of following up is what they're really looking for. How well you do it, I don't think they're evaluating the quality of how well you're doing that. Although, if anybody is on the line from the state of Maryland is clearly evaluating how well their hospitals do that. But that's a state regulation, not a IRS regulation. And be happy if you don't have good evaluation systems and you're not in the state of Maryland, because they not only evaluate whether hospitals are doing their implementation strategies, they are actually evaluating the quality of the evaluation process and publishing the results of that on their website. So that's interesting. But I'm also recommending to people, if they're struggling with, we don't really know how to evaluate what we're doing, how Maryland encourages their hospitals to do it is actually a great format to emulate.
Okay, thank you.
And by the way, yours is there already, Nancy, because when we were working on it, that's what I had in mind as we were going through that process.
Okay, thank you.
Any other questions?
Hi, Deborah. This is Kim and Monica from UMass Memorial in Worcester. We're just on the Maryland model. Is that something we can find easily online, or do you have a sample of what you're...
I'll tell you what. I have a sample from last year. I don't know if they updated it. You can find it on the Maryland Department of Health website. But I'll tell Kathy to send you the example that I have as part of the resources from the webinar today, because
Great.
I do have the download from last year, and it should be sufficient.
Great, thanks.
Mm-hmm. And like I said, I don't know if they changed it this year, but for those of you who are not in Maryland, it's just a great template to use. Any other questions?
Yes, this is Erica Thrash-Fall from St. John Providence Health System in Detroit.
Yes.
And I am wondering, when you do find out that you need to go a different route as far as the things you put into your implementation strategy, for resources reasons, do you need to post a revision on your website, or do you leave it as is and just, somehow do some level of reporting?
I would, and I think the answer to that question is how you do it to some extent is up to you. And this would be my advice. There's nothing in the regulations that say you have to update that implementation plan every year. It certainly is not going to hurt you if you update the implementation plan and post it on your website. That's good PR as far as I'm concerned. You also need to write that down and attach it to your IRS 990 Schedule H when you report that, because they do want to know if something changes. They want you to report that every year. But there's nothing in the regulations that I've seen that says you have to publish that on your website. The time to republish is first I would keep all that history written down over the course of the 3-year period. And I would include that history as part of the evaluation process and the discussion in your community health needs assessment document when you update it. That's where the published version of those changes needs to happen. The IRS requires you to put it in your next needs assessment. There's nothing in the regs that say you have to publish it anywhere else. But and it's interesting, if you read the 64 pages, which made me want to tear my hair out, they did put a discussion in there that people can find it, but they force you to go to GuideStar. So you do have to report it with your 990. But if I want to see it, you don't have to put it on your website. But I know I can find it as a consumer because I can go to GuideStar and find your 990 and find that change because it has to be reported to the IRS. And for some reason, even though that's convoluted, the IRS said that's okay. It would certainly have been easier for them just to say post the thing on your website every year, but they didn't say that, so you don't have to, which is a little ridiculous but true. Does that make sense?
It does. I really appreciate that.
Oh, yeah, and I thought, and they put a lot of thought. I have to give them credit even though it's 64 pages. The actual guidelines, the final guidelines themselves are probably about 8 pages long. But the rest of the 64 are the explanation of how they came to the determination they did. And they gave you the rationale for why they made the decisions that they made, which, again, if you are interested in reading, it's sort of like watching paint dry. If you're interested in reading it all, it's lovely to know. But it probably makes, it's good bedtime reading. But, again, you don't have to publish it every year. But you do have to put it in your 990. Any other questions? Hearing none, I'm going to stop the recording from today and say thank you very much for your attendance and participation. And if any of you have any additional questions, feel free to call me or email me anytime. And if your organization is stuck on any dimension, we'd be happy to help you get past your stuck place and help you move on to where you need to go. So thank you, everyone, for attending, and have a great day.
Thank you. Bye-bye.
Thank you, Debbie. Feel better.